Hello, my name is Gloria Castellano, and I am a registered nurse and serve as a nurse educator and nursing simulation coordinator for the VA of Central Iowa Healthcare System. This training segment purpose is for the brief presentation to provide you a just-in-time training for our colleagues preparing staff to care for patients who may require mechanical ventilation during the COVID-19 pandemic. This education is designed specifically for facilities or healthcare team members who may have limited experience providing this level of care, but who wish to be proactive in ensuring they are prepared should the need arise.
My name is Dana Thorne, and I am a registered respiratory therapist, and I will be the narrator of this brief presentation. Disclosure: there are no financial disclaimers for this education program. Some of the products are not endorsed and simply used for this educational offering. Purpose of education: mechanical ventilation basic overview, application in nursing practice, and prevention of ventilator-associated pneumonia. Objectives: the learner will be able to understand the reasons for placing a patient on mechanical ventilation. The learner will understand the ventilator capabilities, including various models, modes, and ventilation options for the critically ill patient. The learner will be able to engage resources for mechanical ventilation troubleshooting and alarms. Who goes on mechanical ventilation? Based on individual facility parameters, patients will be placed on mechanical ventilation depending on the decision-making team. These are some examples who may need to go on mechanical ventilation: airway compromise, CHF, COPD, respiratory failure, end of life, sputum clearance, surgical, neurological diseases. These are some of the guidelines for normal ventilator settings. Tidal volume of 6 to 8 milliliters per kilogram of ideal body weight. A respiratory rate of 16 to 20 breaths per minute. End tidal CO2 values of 35 to 45 millimeters of mercury. FiO2 of 21 to 100%. PEEP pressures of 5 to 20 centimeters of water, and a plateau pressure of less than 30 centimeters of water. Common sizes of endotracheal tubes are, for an adult female, 7 to 8 millimeters, and for an adult male, 8 to 8.5 millimeters. These are only some of the types of ventilators from the dozens of models across your state. The small portable ventilator on the left is for transport and is MRI compatible. The ventilator on the right is for inpatient settings. Advantages of mechanical ventilation: complies with the patient's flow demand, automatic tube compensation, otherwise known as ATC, SmartCare weaning mode, continuous monitoring of various pulmonary parameters, a power supply unit, reduces work of breathing, improves oxygenation, assists with CO2 elimination, and provides a stable airway. Some of the mechanical ventilators can also be pneumatic, in which no electricity is needed, such as the PowerPack mechanical ventilator. These are some of the modes of a ventilator that you can provide your patient: volume-controlled ventilation, PC-AC, pressure-controlled ventilation, PC-AC, also PC-APRV, support of spontaneous breathing modes such as CPAP/pressure support, and SmartCare. Volume control, assist control, otherwise known as VC-AC, delivers a mandatory preset volume and mandatory preset rate. Patient will receive mandatory rate minimally. Each of the patient's initiated breaths over and above the set rate is delivered at the set volume. PC-AC, also known as pressure-controlled assist control ventilation. Here we are pressure-controlled. This can be machine or patient-triggered. If the resistance or compliance changes during ventilation, the tidal volume will change. PC-APRV, which stands for Pressure Control Airway Pressure Release Ventilation. Spontaneous breathing under continuous positive breathing pressure with brief pressure relief times. To support carbon dioxide elimination, the pressure is reduced to a pressure low for the brief period of low time. APRV is an inverse ratio type of mode with intermittent mandatory ventilation and unrestricted spontaneous breathing that is typically used for refractory hypoxemia. Cautious use with hypercapnic patients. Expect this to worsen. APRV is based on the principle of an open lung approach. It has many purported advantages over conventional ventilation, including alveolar recruitment, improved oxygenation, preservation of spontaneous breathing, improved hemodynamics, and potential lung protective effects. This is a very complicated mechanical ventilator mode and is not for a novice. This is a unique mode in which it is primarily used with patients with such issues such as acute respiratory distress syndrome, or ARDS. Spontaneous, continuous positive airway pressure and pressure support. Here we have spontaneous breathing, continuous positive pressure levels with or without pressure support. If the patient is too weak to manage the complete breathing effort independently, there is an option of adding pressure support. If the lung mechanics of the patient change, the applied volume varies with fixed levels of pressure support. SmartCare. It's important to note that not all mechanical ventilators have this mode. These are proprietary settings. There is no mandatory rate. The ventilator operates in pressure support mode with PEEP. The patient breathes spontaneously. Ventilators monitor 3 parameters here: respiratory rate, tidal volume, and the end tidal CO2. It's a special weaning mode that self-adjusts to the patient's needs. This common mode helps assist in the extubation of patients. Recommended screening type criteria for weaning. FiO2 of less than or equal to 50% with oxygen saturations greater or equal to 90%. PEEP less than or equal to 8 centimeters of water. Heart rate less than 130 beats per minute. Respiratory rate less than 30 breaths per minute. End tidal CO2 less than 55 millimeters of mercury. No increase of vasopressures in 2 hours. Minimal sedation and follows commands, along with minimal secretions. Apnea ventilation. This is a backup mode if a patient in a spontaneous mode is apneic. Mandatory ventilation occurs at a preset level automatically and continues until rest. Non-invasive ventilation. It is contraindicated on unconscious patients. No invasive intubation. Ventilations given via mask versus an endotracheal tube. You can put the patient on and off easily. It works well on patients with CHF and fluid overload, no code or DNR patients, severe COPD that may become vent dependent, and those who refuse to be intubated. It's okay for the RN to remove the non-invasive ventilation. It will switch to standby when removed. Respiratory therapy only should be the ones to resume the non-invasive ventilation. Alarm system. High and low minute volumes, volume not constant, high respiratory rate, apnea, high and low pressures, oxygen and air loss, and power loss. Troubleshooting. For an anxious patient, the patient may need to be suctioned. Frequently, the patient needs medication for anxiety, pain, or sedation to help them relax. Pain is a huge factor in these patients, and all guidelines recommend treating the pain first. Can also be due to a malfunction of a ventilator. Attempt to fix the problem and always call your respiratory therapist. When in doubt, remove the patient from mechanical ventilation. Provide respirations with an AMBU valve bag until respiratory can provide more resources. High and low pressure alarms. When high, check for mucus plugs, and if the patient is coughing, biting, or gagging with their endotracheal tube, also consider checking plateau pressures via inspiratory holds. When alarming low, check to see if the endotracheal tube cuff is deflated or if there are any disconnections in the ventilator circuit. Accidental extubation. Role of the nurse. Ensure the AMBU bag is attached to the oxygen flow meter and it is on. Attach the face mask to the AMBU bag, and after ensuring a good seal on the patient's face, supply the patient with ventilation. Bag the patient and call for your RT. Some consequences of self-extubation are edema and possible vocal cord damage. Anytime you have concerns with alarms, ventilator changes, or any other problem with your ventilated patient, please call for your respiratory therapist and avoid the silence button. Listed below are our references for this presentation. Thank you very much for your time today. This recording was sponsored by the VA Central Iowa Healthcare System and the Iowa Healthcare Collaborative.